looking. Yeah.
That's pretty cool. I saw it. I was all
How do you do on your
Light doesn't come to you. What's going on?
Turn on the projector.
Now, projector is off. No, it's on. No, it's off.
It's on.
It's on?
It's on.
I know exactly which ones I meant.
So it's been. Yeah, this is work.
Yep.
This is work.
Yep.
And how about this one? So this is back, yeah? Which one is back? One is back, one. This is forward, this is
That's
back.
back. This one's back. This is forward.
This is forward.
So press it.
Oh, let me see. Yeah. Okay. So back and forth.
But they move them around too.
Thank you for defending your
No, I'm pretty sure that you sat like there and they moved it here. Well, he used to sit here and I took it. Oh, I saw his.
We're not the
It's right there. I don't think I didn't
Well, I don't know if it's back there or
This meat is right here. I have to.
Yeah, they do.
Sherry, can you get in here?
Yeah, that's good. Okay. Chair is okay.
Five
So
minutes, so
we have 2 more minutes, yeah? Now, according to that one.
he's got two. You guys, maybe I'll go.
2 more minutes.
You guys submitted the police assignment. So
Did you really? You're lying. You're not gonna Just to let you know, we're taking attendance this morning, finishing recap around. Please make sure you sign it.
okay, let's do this.
Okay, so it is 8. Therefore, I will start. Good morning. The topic today, which I will go over that is, let's see.
Let me help you, doctor.
So, which is wrong?
I don't know. We're gonna find out. Usually the device is over here. Let's try turning it. His thing's not connected.
That's not working?
It was, because he went forward back. You saw it.
Okay.
So.
Let's try.
So why it is?
Let me try again. Slideshow. Oh, that's weird.
Okay, so
That was making noises.
it means you to touch that. Okay, so the topic is clinical feature of the gingival and gingival disease. It is 2 chapters. The first chapter is chapter 6. Second one is chapter 7. Basically, it talks about gingiva in health and gingiva in disease. So let me see. Yeah, it is working. So, characteristic of gingiva in health. First of all, it is uniform. It hugs the tooth in a uniform pink color. Color is pink. It might be pigmented. It might not. Now, in here you see this one, which shows no pigment on gingiva. The other one shows pigment on the gingiva. Now, about characteristics, you see it goes, the gingival tissue snugly it's around the tooth, smoothly scalloped. It is scalloped. The shape is scalloped from interdental gingiva, then attached gingiva, marginal gingiva. So this is about characteristic of normal gingiva in health. In other words, in health, when it meet the tooth, it is what? It is a knife edge. It is thin. Now, sometimes it is a little bit thicker, but it is not bulbous. We go into the next category, which is disease. So, let me move to the next part. Okay, so it is going backward, forward, and so forth. So, interdental papilla, you will see it as pointed or blunted. Blunted is when there is no contact between the teeth or there is space between the teeth. You will see interdental papilla is blunted. Otherwise, it is pointed, like you see here. It points interdental papilla. Now, so it talks about consistency of the gingiva. In health, it is firm and it is resilient. So in disease, it is not firm. In other words, the consistency. In health, when you use an instrument, you put on the gingiva, it bounces immediately. But when there is disease, because of edema, because of the fluid inside the gingiva, it won't bounce immediately. You will see it is indented because of that pressure which you put more. In other words, it doesn't come immediately back to the normal state. That shows that the gingiva is not healthy. Healthy gingiva, when you put pressure on that, it will bounce. It shows that it is healthy. Now, then it seems that I should talk about everything, then I come back to this. Now, about the texture, usually you can see, in some cases, you see dimpling of the tissue, like this, like orange peel, which is called stippling. Stippling is what you see right over here. It seems like orange peel. The skin of the orange. So in health, you will see in some cases, not in every cases, but in disease you won't see that. And that's because connective tissue projection between epithelial cell caused this phenomena, which is called stippling. Now, in health, other things which we need to know in health is the color. The color of the gingiva in health is what? It is pink. It is coral pink. Now, in disease, the color will change. Change to what? To red. Why? Because there is more proliferation of blood vessel. Therefore, it gets more red. Now, again, the color of the gingiva in different person are different. It depends on the thickness of the gingiva. It depends on the amount of blood vessel under that area. You will see a difference in different people. Now, next thing which we know, so basically these are about gingiva, about junctional epithelium. We know that in health, junctional epithelium is on what? Is on enamel. In disease, junctional epithelium goes where? Goes to root. Okay? In other words, apical migration of junctional epithelium shows what? Shows disease. Which kind of disease? Periodontal disease. Which one? Gingivitis or periodontitis? Which one? Periodontitis. In gingivitis, again, the position of junctional epithelium is not changed. Now, in gingival disease, in gingivitis, you will see deepening of pocket. The reason for that is not apical migration of junctional epithelium. The reason is because of what? Because of the fluid inside the tissue, which causes the tissue to bulk. In other words, interdental papilla, you will see in some cases when there is gingival disease, it can't fit between the teeth. In other words, you will see it as what? As bulbous papilla, because it can't fit between the teeth. Why it can't fit between the teeth? Because there is an inflammatory reaction, there is edema inside the connective tissue, therefore you will see it like that. So up to now I am talking about gingiva in health and disease. Now we know that when we talk about health, it can be health on intact periodontium. Intact periodontium, it means that the junctional epithelium doesn't change its position, therefore that's called intact. There is no loss of connective tissue previously or bone previously, but we do have also health on reduced periodontium. Again, they divide reduced periodontium in reduced periodontium without periodontal disease, and also reduced periodontium because of previous periodontitis, and after treatment it gets health, so it will be healthy periodontium, but reduced. So remember, when we talked about health, it is either on intact periodontium or on reduced periodontium, which again, reduced periodontium may be because of not periodontitis, other condition which cause what? For example, traumatic condition which cause traumatic brushing, cause recession, which cause reduced periodontium, and but it is healthy. Now, also we can have healthy periodontium because there was periodontal disease. You treat it, and after that, no periodontitis. How can you say that there is no periodontitis? When you probe, you see no bleeding. You don't see those signs of inflammation, which are what? Which are edema, tissue which is bulky, which is what? Color change, red color. You don't see, then you know that you are dealing with periodontal health, but reduced periodontium. So remember, when we talk about periodontal health, it can be on intact periodontium or on reduced periodontium. So, now these slides show inflammation. You will see the inflammation. Either we do have, usually it starts in papillary area, right at this area in papilla. It starts in papilla. Then it might go to marginal area. So in other words, when it goes to marginal area, we call it what? Marginal inflammation or marginal gingivitis. Now, marginal gingivitis is composed of two parts. One is here, in other words, papillary gingiva, and then marginal gingiva. So when you hear marginal gingivitis, then it comes to your mind that two area is in this area. Okay, one is what? Papilla. The other one is in other words, the free gingival margin. So marginal gingivitis is what? Is papillary and marginal tissue involvement of inflammation. Now, in marginal gingivitis, also the contagious part of attached gingiva get involved. Now, when the whole attached gingiva and marginal and free gingiva and papillary gingiva get involved with inflammation, then the condition is called diffuse gingivitis. So this is red marginal gingiva and papilla and marginal gingiva. Now, when diffuse gingivitis, either it will be just one tooth or a section of tooth like here. So anyhow, this is talking about the papilla, which I told you. In disease, you will see it. Papilla, in disease, you will see either bulbous or blunted or cratered. Now, bulbous is when the tissue, the interdental tissue cannot feel the interdental area. That is bulbous. Now, blunted is when you can see between the teeth. In other words, you will see what? Recession in interdental area. Now, crater, this is bulbous papilla. Papilla cannot feel between the tooth, it bulk out. So, bulbous interdental papilla, and you see my inflammation, which you see which kind of inflammation? It is what? Papillary and free gingival margin. So in other words, marginal gingivitis. So usually in order to prove that it is gingivitis, you need to show that there is no bone loss. In other words, you need X-ray, or you need to not detect attachment loss by your probe. Then you know that this is gingivitis. Otherwise, you go to the next category, which is periodontitis. So now, why this doesn't like me? I think so. Let me see. Yeah. So this is blunted papilla. You can see between the teeth. The interdental papilla receded down. So this is because of, now, this you can see it either in health with reduced periodontium, you can see. So in other words, it is not always in gingival disease or periodontal disease. You will see here it's periodontal disease. Actually, it is held on reduced periodontium. Why? Because you don't see any sign of inflammation on these areas. Now, next one, it was about crater. It should be somewhere. Okay, anyhow, this is characteristic of healthy and gingivitis. It talks about CEJ. In reference to the CEJ, marginal, in other words, if there is healthy tissue, the margin of the tissue is slightly above CEJ, coronal to CEJ, but in health also, in those cases which you do have reduced periodontium with health, you know that the margin of the tissue is slightly apical to CEJ. So in other words, in intact periodontium, margin of the gingiva is slightly above CEJ. Now in gingivitis, again, margin of the gingiva is where? Above CEJ, unless the situation is what? Is a reduced periodontium with inflammation. Now, how we define that this is reduced periodontium with inflammation? Because either it is because of non-periodontitis, there is reduced periodontium because of trauma from brushing or other things, and then gingivitis on the tissue, in other words, inflammation of the tissue, it will be called reduced periodontium with inflammation, or when there is no periodontal, in other words, there was periodontal disease, it was treated, and it was okay for some times, and suddenly it started again inflammation, to show inflammation, then it will be what? It will be reduced periodontium with inflammation. So in other words, those cases which you treat, and then in reevaluation you see, everything is stable. Probing pocket has reduced, and in some area less than 10% you do have bleeding on probing, then it is called healthy. Now, if you in the maintenance phase, you will see the same patient, and the same patient shows more bleeding on probing and some inflammation, then it will be what? It will be reduced periodontium with inflammation. And in that case, margin of the gingiva is below CEJ. But usually in intact periodontium, marginal, the gingiva is slightly above CEJ. About consistency, we talked about that. In periodontitis, it is spongy. In health, it is firm. So now, okay, spongy tissue, soft and spongy tissue is characteristic of what? Of health or disease. It is characteristic of disease. Why? Because of the inflammation, because of the inflammatory process which cause this situation. So now, texture also, we talked about texture, which in the book it says that it will be, in disease, it will be like a plastic wrap. In normal tissue, it is smooth. So when you see tissue is shiny and smooth, then you know that something is going on. In other words, there is no fluid, there is more fluid under that tissue. Therefore, you will see it shiny, which is important in clinic. When you see tissue is shiny, you know that there is something going on underneath. And usually, you can detect it in anterior area very nicely. So that's about shininess of the tissue. Okay, so this shows normal periodontium. Now, because of you see some redness over here, therefore you know that it is papillary gingivitis, and it's usually start from papilla Now, book is talking about descriptive term. In other words, you need to describe what you see. It is very important what you see, but you need to document that. And these terms which you see in the book about flaccid and blunted and so forth, it is important to use that so that when you write your note, you saw these things, so that the next person knows what was the situation before. So it is very important to describe the situation you see. So that's very important. Now, then about terminology. We do have extent of the disease. Either it is localized, in other words, it is localized to one tooth or a group of tooth, or generalized, which most of the teeth are involved. Now, how we decide that? Most of the teeth are involved when you count the teeth, and it is more than 30% of the whole area, then it is called generalized. So generalized, it doesn't mean that you should have every tooth involved. When you count the area with gingival inflammation, and you see that it is more than 30% of the total tooth in the mouth, you call it generalized. So that's about extent. And now, diffuse means that you will still get inflammation of papillary, marginal, and attached gingiva. Now, it can be localized, it can be generalized. Localized, one tooth or a group of teeth get involved. Generalized, more than that get involved. Less than 30% of teeth get involved. You call it generalized. Okay, so again, localized marginal, yeah, I told, this is localized. Why? Because just is on, now, this is what? This gets, again, localized because just anterior part of the mouth is involved. You see, from posterior, it is not involved, but it is diffused. Why it is diffused? Why it is diffused? Why? All over. What we mean by all over, in other words, papillary, marginal, and attached gingiva are involved. Therefore, it is a diffuse inflammation. And you need to describe the inflammation. Interdental papilla. How do you see interdental papilla? Do you see it cratered? Do you see it blunted? Do you see it bulbous? Which one? Bulbous. You see bulbous interdental papilla. Now, how you describe marginal tissue?
Shiny.
Yeah, shiny. Exactly. Shiny shows that there is what? More fluid underneath because of the reaction in of the inflammatory process. So in other words, in health, you won't see bleeding on probing. In health, you won't have erythema. What is erythema? It is redness. Now, what is edema? Edema is swelling. When you see it is more than what you need to see, it is called what? Edema, which is because of the amount of fluid inside the tissue. Now, also no symptom. Now, what symptom? What is the difference between symptom and sign? Symptom is what the patient complain about. Now, sign is what you see clinically. Now, symptom like what? Like the patient is talking about bad odor, or these are symptoms, yeah, which is symptom of periodontal disease, or it can be symptom of bad odor from what? From lung. So these are the symptoms. But for example, bleeding on probing, is that symptom or sign? It is sign, because we use the probe and we see bleeding on probing. So patient symptom is absent. Patient is not complaining about anything from gum or from gum, basically. Now, then there should be no attachment loss. Now, in which cases we do have bone loss? In cases which is reduced periodontium with health. In that case, you do have bone loss, and you do have also attachment loss. So remember, in intact periodontium, in health, you don't have attachment loss or bone loss. But in reduced periodontium with health, you have both of them. But you don't have bleeding on probing, you don't have erythema, you don't have edema, and the patient is not complaining. Patient may complain because of food impaction, because interdental area is open. But basically, those symptoms of gingival disease, patient is not complaining, which you should know what are those. Why you should know? Because it is in the book. Why it is in the book? Because patient complained. Yeah? So this is about characteristics of patient periodontal disease. Now, let me go to the next category. Category of periodontal disease, I talked about that. In other words, periodontal disease, periodontal health is either on intact periodontium or on reduced periodontium. Reduced periodontium, again, they categorize into reduced periodontium with non-periodontal patient and reduced periodontium on previous successfully treated periodontitis case. So we talked about that. So I need to make sure that everything was covered. Yeah, you will see this slide. Now what you see root inside the mouth, yeah? From this part on, yeah, you see root, this part. Now, how do you know that it is root? The color is different. It is slightly more yellow. Now, why it is yellow and why crown is white, root gets yellow? What's the reason for that? In other words, in what part of cementum we cause yellowness of this part? Now, anybody knows that? I'm not sure. That's why I'm asking you. If you know, that's it. But there should be a reason why we see more yellow on cementum than on crown. Now I need to go over that to see if anybody went after this subject. The subject is what? Why you see more yellow on a root than on crown. So what's the wavelength of yellow and what's the wavelength of, anyhow, those goes to physics. So basically you will see here we do have what? Reduced periodontium. Now, do we have gingival inflammation on reduced periodontium here? When you look at here, you can say yes, yeah, or you can say no. Which? Now, if you see shininess, which you see, does it show that always there will be inflammation? Now, what's the first sign? The book is talking about the sign of gingival inflammation, the first sign, usually. They talked about bleeding on probing. They will say that that's the first sign. Now, is that the first sign? But the book is talking about that. And how can we be sure that that's the first sign? Now you can make a statement. No, that's the second sign, because I see what. Now I don't remember whether this in the book they call it as healthy but reduced. So in that case, what is that shininess? Because of the bouncing of light, or what, or no what? So anyhow, these are the things. I don't want to confuse you. But the important thing is that don't accept everything the book says. You need to know the reason for that. Yes?
Is it possibly because of the roots have more dentin?
The root is more what?
Dentin?
Dentin. Oh, okay. The root has more dentin. In other words, the enamel will mask dentin. The cementum cannot mask dentin part of that. It might be. I don't know. Now, the color of dentin, is it more yellow than the crown, the enamel? So, yeah, it might be. But that's a good point. Yes, what was it?
I was going to say maybe because it's covered by the gums, so it turns darker.
By the cover, maybe. Anyhow, we need to prove these. These are very good subjects, but you need to prove that. Yes. Yeah, mineralization. Yeah, definitely. Now, what's the difference between mineralization of cementum and the mineralization? Now, in other words, in what do they have the same mineral? First of all, then the same content. So yeah, it can be, but somebody should sit down and analyze these things. Very good point. Yeah. So each one has good point. So in other words, whatever you think, let the other person know that. I mean, they can help, and actually, you can work on that. But sometimes it is easy, sometimes it is not. You start and then you see different things come. But it shows that, in other words, you as a clinician, you should also think about other things. In other words, you can bring something new to the profession by asking. And then don't hesitate to ask. I mean, it is very important. When you ask, then sometimes it comes to your mind, the answer. But if you don't ask, it won't. Which happened to me. I'm asking, and suddenly it comes to my mind. I ask immediately, then I get some feedback or feedback from myself. So don't hesitate. I mean, when you read these things, you need to question why they said this is the first sign. Now, what's the evidence they are giving? But as a lecturer, I need to let you know the first sign which you need to put in your exam, if we ask, is what? Bleeding on probing, according to the book. Now, then there are other questions. That's something else. But basically, you need to know what the book provides, and then when you read it again, you will see differently. And this is very important. That's why you need to read it again and again, and you see different things in different time. Now, let me see. So in here, you see that there is bone loss according to the X-ray, and on the picture, according to the book, I think they put it no. In other words, it is reduced periodontium with healthy and reduced periodontium. Now remember that according to the new classification, 2017, if there is only less than 10% bleeding on probing, it is called as what? As healthy. But if it is more than 10%, then it is with inflammation, reduced periodontium with inflammation, or if it is intact, then periodontium, it is gingivitis. But less than 10%, they call it normal. Now, why they call it, healthy, less than 10%? Why they choose 10%? So, first of all, you accept, okay, 10 less than 10%. And you get happy that up to that, it is healthy. But later on, you will think, why did they choose 10%? Why they didn't choose 20% or 15%? So these are the things which you need to think about that. In other words, accept whatever the book gives, but you need to, for the future, you need to put your input. This is very important. Because in order to get to this point, many persons gathered they used so much time and money. Then they came to this conclusion that what? Gingival disease and condition, which is part of periodontal disease. They divided into gingivitis. Then gingivitis, which kind of gingivitis? The dental biofilm induced. And then the other gingivitis, gingival diseases, they call it what? Non-biofilm induced gingival disease. So they came to this conclusion. Okay? So, in other words, gingival disease, either it is biofilm induced or non-dental biofilm induced. Now, remember, dental biofilm. In other words, we do have biofilm, but when we call dental biofilm, it specified it, that it pertains to what? To teeth. Dental biofilm induced, non-dental biofilm induced gingival disease. So they came to this conclusion. And then they went to what? Or first of all, they go to all those diseases and then they decide, okay, it's better to call it this way. Now, in order to appreciate what they did, you better go back and see what they did in 1999, 1989, and previous to that. Because from right at the beginning, they went as Schmut pyoria and so forth, dystrophic gingivitis. You will see different terms. So finally they come to this conclusion. Now remember that at 9 o'clock you do have 10-minute break. Now, plaque-induced gingivitis characteristic. First of all, it is most common form of periodontal disease. This disease, which is plaque-induced disease, is what? In other words, it is precursor of gingivitis. In other words, gingivitis will not, periodontitis. Periodontitis will not start. It will start on existing gingivitis. Now, gingivitis may be present for years without converting to periodontitis. Or it might be very short. Now, if it is very short, it is called what? Acute gingivitis. Now, if it is, it takes more than a few weeks or so, it gets to chronic chronic gingivitis, which can be years. And sometimes it will never convert to periodontitis. And it is plaque-induced. In other words, the etiology is what? Dental plaque. But I mean the destruction, which is destruction of what? Of connective tissue, and infiltration of inflammatory cells into connective tissue of the gingiva. That cause what? That cause this condition. But it is not just the plaque. In other words, it is starting with dental biofilm plaque, dental biofilm plaque. But the reaction of the body is what it causes what? Inflammation. In other words, the body reacts to those pathogens in the biofilm. And it causes destruction of what? Of connective tissue. It causes the ulceration of epithelium. Now, how it causes ulceration? Now, does ulceration cause penetration of those pathogens into connective tissue? Can you see that into connective tissue? Or usually you can't see. Now, dental plaque in which area cause gingivitis or gingival inflammation or reduced periodontium? Just at the marginal area or subgingival? So both of them, just at the marginal and subgingival. Because of those then the process start. But it start, why it start? Because the body react to that. And then inflammatory process will cause. Because previously they thought that plaque will cause gingivitis or periodontitis. No, the reaction, that's why in some people you will see plenty of plaque, but no disease. And some people you see very slightly plaque and disease. Why? Because in that person was active himself or herself, and the body was also active. So reacted, and you see destruction. Now, the other thing is that gingivitis is, you can see in each age group. In other words, you can see in very young people or in old people, you can see gingivitis. It is not just you tell, okay, we see gingivitis just in young. No. According to the book, prevalent at all ages in the population. Remember, at all ages. So again, a characteristic of plaque-induced gingivitis, it talks about that. Sign and symptom. Sign is what? Bleeding and probing is the first thing which you will see. Symptom, patient may say that I have itching of gum, or bad odor, or different things. So in here you will see here right at the papillary area. Okay, so this was papillary area. Right at papillary area, the gingivitis started in papillary. You see, this is papillary gingivitis. Now, when it involved the marginal, okay, so here it extends also to marginal. Then remember that if it gets chronic, usually the body will deposit what? Collagen fiber in the area which inflammation happened. Therefore, you will see what? You will see that the tissue is bulky. And that's because of what? Because of the body reaction and deposition of more collagen fiber in the tissue. So now next one. Then in the changes in color, so we talked about that. Edema is swelling and so forth. Also, patient may complain of tenderness of the gingiva. So that's one sign of gingivitis. Now, we know that clavicular fluid also increased in gingival inflammation. Clavicular fluid comes from where? From connective tissue, yeah? It comes from blood vessel, then comes to connective tissue, and then you will see clavicular fluid. Now, the subgingival plaque is subgingival plaque in subgingival calculus. And the subgingival plaque and supragingival plaque, they are not the same. Now, calculus, are they the same subgingivally and supragingivally? They are not the same. In other words, calculus in here, it has what? Clavicular fluid is where it is, sitting there, clavicular fluid is there. But in the mouth calculus, what we have? We do have saliva. Now, inorganic substance of calculus comes from where? Comes from where? Saliva for supragingival, and for subgingival, from where it comes? Clavicular fluid. It doesn't come from saliva. Why? Can the saliva go to subgingival area? No, because usually, we distend the pocket. Usually it is tightly hug the tooth. So these are sign and symptom. Now we talked about that reduced periodontium and so forth. So we talked about this. So you can read it what we talk. And also I talked about that. Now, according to this one, this is reduced periodontium in a successfully treated patient. So it can be because of what? Non-periodontitis. When you see recession, then it can be because of non-periodontitis. How do you know which one is that? Is that because of non-periodontitis and then you have reduced periodontium? You know that by 2017, in order to define periodontitis, they go after pocketing, which is 4 millimeter depth, pocket depth, and more, and bleeding on probing. Then they call it what? In other words, interproximal area. They go after that periodontitis. Now, if you see recession and you see bone loss, in other words, there was bone loss and there is attachment loss, it can be, it is called what? Reduced periodontium. Unless you do have 4 millimeter depth interproximal area, which I think they defined on 2 non-adjacent tooth, something like that, then you say that this case has periodontitis. Otherwise, it is reduced periodontium. Now, if you see bleeding on probing, more than 30% on that dentition, it is called what? Reduced periodontium with inflammation. If you see bleeding less than 10% of the total mouth on that periodontium, it is called what? Healthy but reduced periodontium. According to what? To the classification on 2017, which they started to work on that from 2015, and finally in 2019 the whole things came that this situation is called periodontitis and so forth and so on, and you need to use it. So anyhow, you do have these things, but anyhow. So the other thing which they talked about is what? About the factors which contribute to gingivitis, to gingival inflammation, to inflammation. Those factors, one of them is what? Is associated with sex hormone, which you can see the effect of sex hormone in puberty, also in what? In pregnancy, also in menopause, you can see the effect of that. Now, in puberty, you will see what? In other words, the same amount of plaque. First of all, we know that in adult, gingivitis is different than in child. In other words, the child may have more plaque, but it shows less gingivitis. In adult, it shows more. Now, the reason for that is development of immune system in the adult. And in the child, it is not so developed. And we know that the reaction which we see as gingivitis is because of what? The body response to plaque-induced infection. And generally, you should know that gingivitis or periodontitis is infectious disease. By definition, infectious disease is disease which is caused by what? By bacteria, by microbe. Microbes are what? Can be bacteria, can be what else? Fungus, can be what? So by microbes, then it is called infectious disease. So when we talk about gingivitis or periodontitis, we are talking about infectious disease. Now, the other kind of disease which we have in dentistry is what? Is trauma from occlusion, which is not infectious. It is because of what? Because of pressure, because of trauma. We get the same, we get what? We get bone loss, but it is not because of infection. It is because of pressure. There is bone loss, therefore you see what? Widened PDL is because there was bone loss on PDL space. It was not because we know that bone is a living organ. It will resorb and form. When resorb and form, that's normal, but if it resorbs and it doesn't form because of pressure, or it cannot compensate for the resorption, then we get what? Occlusal trauma. Okay, so this is an example so that you remember always. Gingivitis, periodontitis. Periodontal disease are infectious in nature. And by infectious, we mean what? The etiology is biofilm or, fungus or whatever, but the nature of the disease is the reaction of the body toward that agent, which causes destruction. And in some cases, you have all those, all those bacteria or whatever, but you don't see the reaction. The reason is what? Because that person, the immune system didn't react toward them, then you won't see it. So, now, puberty is one example. Now, in other words, with the same amount of plaque, in puberty you will see more reaction of the tissue. So this is very important to know. Now, then beside sex hormone, we do have what? Diabetes. Diabetes also is a contributing factor. In other words, the diabetic person, it will show, the same amount of plaque, you will see more response of the tissue. And when when you remove plaque, also it has effect. Then you will see that A1C will get lower. So in other words, they contribute to each other. So in other words, from A1C, I think from 8 or from 10, then you should be careful. But before that, you can treat the patient. You need to make sure that they control that by, medication or whatever, which they give you in the clinic. So this is another factor. Then now, the next factor which you need to know is, by medication. Medication also, it modified gingival inflammation. Those medication which modify gingival inflammation are what? Are beta channel blocker, which they use it for blood pressure, to reduce blood pressure. Also anticonvulsant medication, which they use in those persons which have problem with mentality, they use it now. And also for anyhow, I don't remember exactly what was that. It should be somewhere here. You can read it. So there is 3 condition medication which modify gingival inflammation. One is immune suppressant. Immune suppressant, they use it so that, when they transplant something, it won't reject. So it doesn't mean that in every person which is using those medication, you will see the reaction. Usually, which kind of reaction you will see? In this case, you see cyclosporin, which is immune suppressant. It will cause a deposition of more collagen fiber. It starts first in interdental area, and you see that it went forward. Usually, when they use medication, if it shows the effect in the person, after 3 months, you will start to see the effect. Before that, you won't see that. So remember this thing also. So these are the factors which can modify the response of gingival tissue or periodontium to inflammation, which one of them was immune suppressant the other one was anticonvulsant, and the other one was beta blocker, which they use it for high blood pressure. So in 5 more minutes, you do have 10-minute rest, then we will start it again. So countdown started, yeah, okay. Now, if you have any question, okay, so then something else. Any question? No question? Okay, that's a good question. Yes?
Will there be any pictures of these?
Previous picture.
Any pictures
Any picture? Okay.
on the test?
Any picture? This picture.
This picture we have?
Say that again.
On the exam. On the exam.
Oh, on the exam. On the exam, yeah, there might be picture, yeah. On the exam, there might be picture. So my advice for you, I mean, to better understand the whole topic, it is better to write first the first line of the chapter. Then it is better to see those pictures and read that. And then it is better to go, then you get into some question. Then go after those questions. Then you will remember. And it will be easy. And yeah, in the exam, you do have picture.
Are there any questions in the book?
Say that again. All questions I get from the book. So it is very important to read the book. I try to put everything on slide, which you see. Most of the things are on slide. And again, one of you asked for a study guide, which I think you were. Yeah. So I also put study guides. But I don't go after those things. In exam, I go into the book, and then from the book, I will give questions. But I will try to cover everything in the book, and even more than that in the lecture. But it is very important for you to read the book. When you read the book, you remember the book in that page, what was written. And actually, I had one student which he knows exactly on which line what was written. Very good memory. I never forget it. Among you, there might be somebody like that. In other words, they will read and they remember exactly where was that or something. So that's the talent which some people have it, some people don't have it. But I use the book because I want to be fair to everybody. In other words, nothing outside of that, because you might not listen to what I said, or I didn't cover what I was going to cover because of, time or whatever. But the book is for everybody. So I think, yeah, it is time. In 10 more minutes, the session will proceed. Now, everybody make sure that we get attendance today. So make sure whoever came, they put their name down. Good morning.
I fell asleep. I was late.
No problem. Put your name down.
I think she took it.
Oh, she took?
Yeah.
So why not check with her when she comes? She will come.
She will come back?
Yeah.
Thank you so much.
No problem. Don't worry. Just tell her, and I will also tell her.
Thank you.
Okay, no problem.
She has the same problem.
Is there a problem? No problem. When she comes, let me know. Yeah. And thank you that finally you came. Because I know because of different. No, because of different things, one might not be on time. I understand that.
Thank you.
But thank you that you came finally.
So for the next week exam, just فقط کتاب بخونم اونجا یا برای next
که
exam
فقط
day.
اگه کتاب بخونی
از PowerPoint تنها
PowerPoint تنها نه. ممکنه یه چیزی نباشه و نزده باشم تو اونجا آورده باشم ممکن چیز باشه ولی معمولا پاورپوینت همه چیز رو معمولا
خیلی ممنون.
So these ones are ones from.
Yeah, and then also have the.
Yeah.
I'm going to do the drain away.
Yeah.
Okay.
That's
Okay.
I
This might break here, but I'm just gonna try.
Yeah.
I think the times I broke, like I was putting it on wrong.
That's what we're going
Yeah. Yeah, it was good. It might work. Okay. I think we'll do it. Yeah.
Okay, you see you buy her.
Yeah, I did buy hers. Yeah, but it's just some of them.
So you have to right?
Yeah, did you need that?
Well, then I'll do someone else to do it.
Yeah.
Oh, yeah?
That was good. Yeah,
But it just feels like a lot of
and then I have the
holes.
So this one.
No. So I just
Yeah. Okay. Okay, sounds good. If I have any left over, I'll give it to you. Yeah. Thank you. Yeah.
for sure that the new ones can fit my suit.
Okay. Yeah. Thank you.
What is this? Grace thought that was funny.
I have an extra set.
Oh, you do? Yeah, how much are you selling it for?
$12.
For one set?
Yeah, but it includes all cassettes.
Okay.
Party this weekend? Oh,
You can
yeah.
just have
I don't think I can
You said it?
Oh, you didn't get it? Okay, I've been with you like literally last, like the day that I was texting you, I was like, oh. I would have forgotten. I went to the wrong person. Oh my god, yikes.
Oh gosh.
No, wait a second. Wait, hold on. I think I said both the wrong person. Why is your name so hard?
Yeah.
Yeah, eventually I was like, okay, I'm done.
Wrong person.
I was waiting.
No, you're good.
Yeah.
So yours?
Oh.
Yeah.
You probably look at
This is the
You had two? Oh my god, that's why.
Yeah, I can't like.
Oh.
I don't know why. Is there a way to message? Oh, I don't care, but it's. Yeah, oh my god. I feel like you're slacking on your like skipping.
Oh, you did?
Yeah.
I wrote the reason for like reading through it and writing it.
care about this, like nothing.
There's a bunch of like form of
kind of understanding, but I'm just like, I'm just gonna write something as
Yeah, bro. Like, oh yeah, I agree with this.
I know. Oh man.
Like I got the last one, I got all wrong. Just my brain works. But like I'm the
Right now, like don't have that. Okay, this is for me and Sandra. Oh, wait,
Okay, so
$92 short. I picked the wrong one. Okay, it's for me and Sandra. Do you have change? Okay, fine, together. I have Jack.
okay, so everybody are here or there. Okay. So we were talking about plaque-induced gingival disease, and then we were talking about modifying factors One of them is modified by nutrition, malnutrition. Now, malnutrition you will see in infant, you will see in elderly patients, you will see, in other words, in institutionalized elderly, which are on those home care. Then you have also alcoholic. You will see in these kinds of person, what you will see malnutrition. Now, a good example of malnutrition is deficiency of vitamin C, which you will see on the next slide. So, on this slide. So, deficiency of vitamin C, it will easily bleed the gingiva. You will see the gingiva is swollen, interdental area, you see what's happened. And then it is also, the color is bright red. So it is gingivitis, and the modifying factor is nutrition, which is vitamin C deficiency, which is called what? Scurvy. Usually you see on those sailors which are on boat for what? For months. So we know that vitamin C you can find in fruit, in vegetable. When they are not using vegetable and fruit, then after a while they get what? Deficiency, so you see a deficiency. Therefore you know that there are some modifying factors which cause, which accelerate, or it will show more effect of inflammation on the gingiva. One of them is malnutrition. The best example is vitamin C deficiency. Now, next category of gingival disease. This is non-plaque induced gingival disease. Now, again, you see, they subclassify under these things. Genetic, then infection, specific infection, beside, in other words, not biofilm-induced infection. This is specific infection. Like, then we do have bacterial origin, which we do have necrotizing periodontal disease. It can be because of these things, treponema, selenonomas, fusobacterium, and you name it, Neisseria, Mycobacterium tuberculosis. Now, treponema, we know it is the disease which causes what? Syphilis is from treponema. You can see the effect of that also on the gingiva or on the tongue. In other words, in oral cavity. This is called what? Non-plaque induced, if you see, non-plaque induced gingival disease. Now, then viral origin, also infection from virus inside the mouth. Now, example of that is what? Herpes simplex. If you see on the gingiva, you see, in other words, sign of inflammation, which is what? Redness, swelling, edema, and so forth. And it is because of herpes virus, it is categorized under non-plaque induced gingival disease, or gingival disease and condition. They use condition. You remember in this classification, 2017, they have condition after several things. So about viral origin, now about viral origin, you see how many different type of virus they can cause non-plaque induced gingival disease. Now, next one is fungal candidosis, which you will see, if you see, usually is under full denture or partial denture. It looks, you see, white, so something like that. Usually these kinds of disease, which is non-plaque induced, they are painful. The patient complain of pain and come because of pain. But in the previous type of gingival disease, which was plaque, biofilm-induced plaque disease. Usually they are not complaining of pain. Yeah, sometimes they will say, okay, the tissue is tender, but in this one it is painful. Non-plaque induced, which can be each one of these. Okay, and it comes the rest. Inflammatory and immune conditions and region. Under that category, again, we do have hypersensitivity. You will see contact allergy, plasma cell, gingivitis, erythema multiforme. These are what? When you see on the gingiva, it is called non-plaque induced gingival disease and condition. And for example, erythema multiforme, there is, you see the signs on the skin. Also, you see, actually, the book is saying that the first, most of the time, the first sign will be seen in erythema multiforme in the mouth. So it describes how it is. Now, we do have, so that's it. Now then, granulomatous infection condition, which is what? These two things, Crohn's disease and sarcoidosis. You can see also inside the mouth on the gingiva, it is under this category, which is what? Non-plaque induced gingival disease. So let's go see what we have here. Then it is continuing. You see how many different type of disease you can see in the mouth, on the gum. You can see here, epiulitis, which pyogenic granuloma, which you can see in pregnant patient, which is like a kind of small tumor between interdental area. Then neoplasm. Also, you can see sign of neoplasm. The best one is what? Leukoplakia, and then which is neoplasm, which can be malignant or pre-malignant. Pre-malignant leukoplakia, erythroplakia. These two things are pre-malignant. Malignant leukemia and lymphoma. You can see on the gingiva. The sign you see on the gingiva, it is not plaque induced, but presence of plaque makes the condition worse. But it is not plaque induced. In other words, it is induced. It is non-plaque induced. It is because of the situation the patient has, which is leukemia, which is cancer of what? Of blood cell, white blood cell. So endocrine and nutritional and also metabolic disease, which non-plaque induced is what? Again, they classified it under non-plaque induced. But when plaque is present, it will show more reaction. So I think in the book they put it both way, but in actuality it is non-plaque. It is because of malnutrition. Now you remember malnutrition, we put it in plaque induced. Again in here regarding metabolic diseases, they put vitamin deficiency as metabolic disease. And they put it vitamin C deficiency. So you see that there are different situations which is called non-plaque induced gingival disease. Now, necrotizing periodontal disease, you should know this entity. Necrotizing is what? Is caused by bacteria. It is categorized under what? Non-plaque induced gingival disease. It is caused by bacteria, and it is because of what? Because of smoking. In other words, the factor which cause, in other words, it will make the patient ready for this situation. It is what? It is smoking, stress, poor nutrition, compromised immune status, then the patient can get this kind of gingival disease, which is non-plaque induced, but it is by bacteria. Now, the type of bacteria, they put it down. Different things can be. Now, in necrotizing periodontal disease, if there is no loss of periodontal attachment, it is called what? It is called necrotizing gingivitis. Now, when it is a loss of attachment, then it is what? It is called necrotizing periodontitis. Now, again, I think they categorize it necrotizing periodontitis on reduced periodontium and on periodontitis. In other words, after periodontitis. So in the characteristic of that, you will see usually it starts in interdental area. And then, in other words, interdental papilla get involved. Then you will see loss of papilla. In other words, you will see punched out papilla. Or you will see cratered papilla in interdental area. When you see cratered papilla, then you should be suspicious of necrotizing periodontal disease, which can be necrotizing gingivitis or necrotizing periodontitis. Now, how do you know that it is periodontitis, necrotizing periodontitis? When you can show that there is attachment loss clinically or radiographically, you will see bone loss. Now, do you usually can detect attachment loss first and then radiographically can you see bone loss later, or vice versa? Which one? Which one do you think you will see? No, you will see, in other words, you can detect clinically attachment loss, but you might not see radiographically bone loss. Because according to the study which they did, you need to remove, they did study on cadaver, 1/3 of the, and then something else, you know that a bone loss interdentally you can see on the x-ray. On direct you can't see. So therefore you might have recession, you can see clinically, you can measure attachment loss, but you can't see on the x-ray. So usually, clinically, you will detect attachment loss first, even in interdental area. And later on, you will see bone loss. So, I'm talking about necrotizing periodontal disease, which is caused by those things which is not it is non-plaque induced, but it is by microbe, by bacteria. The type of bacteria they mentioned that. Now this shows necrotizing gingivitis. You will see punched out papilla. Papilla in between the teeth, it is punched out. It is painful. Therefore, patient comes because patient has pain. Now, why in this situation you see pain and on the other gingivitis you are not complaining on the pain? Because when you see punched out papilla, it means that what? That in other words, the connective tissue has been destroyed. There is no, usually when there is epithelium on something, there is no pain. But when you remove epithelium on any part of the body, then they will feel pain. Why? Because in epithelium we don't have nerve. One will not feel anything, but in connective tissue there is nerve. Therefore, it is painful. Patient come because of pain. This is an example of necrotizing gingivitis. Why it is gingivitis? Because it is not periodontitis. Why it is not periodontitis? Because there is no attachment loss. Okay? Now, how we know that there is no attachment loss? We use a probe, we go after CEJ, we can't find CEJ. It is not present. Therefore, we know that junctional epithelium is covered the whole root. We can detect it. So if we can detect CEJ, then it is attachment loss. Now, how much? From that point on, we measure, and then we know that how much attachment loss we have. Or they call it CAL, C-A-L. Like Cal train, this is Cal what? Cal tooth, or something like that. So whatever you call it. So I think next time I need to use my laptop, because this is, now it's a good exercise for me because I should press it several times. So it is good for my finger, but it takes time. Now, other bacterial infection, which is what? Bacteria not the bacteria not commonly found in plaque biofilm and cause infection. Those are other bacteria. It can be different things, and I talked about that. Usually, it is painful, and it caused. Now, and the example is Neisseria gonorrhea, Treponema pallidum, and so forth. These are examples of other bacteria. Now, primary hepatic gingival stomatitis. This is from what? This is viral infection, and initial sign is characterized by redness, multiple vesicle, rupture, and then you will see ulcer, painful ulcer. Patient complaining of pain. Now, usually you will see in young adult. So this is primary hepatic gingival stomatitis. Now, next one. Again, my exercise. Other virus infection, which you can see also in the mouth. It is written here. So you can read it. Okay, this is an example of primary hepatic gingival stomatitis, which you will see on the tongue, on the palate, on the gum. So you see also the lesion, which usually it is vesicle, then it ruptures, and when it ruptures, it is painful. Why? Because connective tissue is exposed. So that's example of primary hepatic gingival. Fungal origin also you will see on the gum, which best example is candidosis and mycosis, which can be histoplasmosis or aspergillosis. So again, my exercise. So yeah, it talks about allergic reaction in the gingiva. Usually because of toothpaste, some people get allergy. It has different ingredient toothpaste. So they will see it is fiery red. You will see fiery red marginal gingiva. It is because of what? A reaction of the body toward that specific ingredient in toothpaste. Usually when somebody gets that situation, they report it, and then they will remove it or they will modify it. So it doesn't mean that the patient should not use that toothpaste again. They might modify it, so we need to check that to see. Immediately they will modify that so that they won't see those conditions on other persons. So that's about allergic reaction of the gingiva, which is what? Non-plaque induced. Here there is no plaque involved, but you see gingivitis, and it is fiery red. So again, now I think it's something else comes in between. Anyhow, so oral lichen planus. Okay, lichen planus, you know that there is different type of lichen planus. I think it was 7 type or 5 type. It should be written in the book. Now, characteristic, when you see in the mouth, you will see what? Mostly you will see the reticular form in the mouth. On buccal mucosa, you will see, on the gingiva also you can see, but we know that lichen planus, it can be manifested in different shape, which we categorize it. One of them is, reticular form, which usually is more prevalent on the in the mouth. Now you will see again characterized by it is itchy, swollen, rash on the skin or in the mouth. You can see on the skin. Sometimes it's in the skin, also in the mouth. Then it is painful and can last for many years. You can have. You might get some patient with lichen planus, which you will see again and again. The same reticular pattern you will see on the cheek or wherever. Now, so lichen planus, again, it might be because of sensitivity to something. In other words, immune reaction, allergic, which is sensitivity, or immune reaction to something. So we see lichen planus. Why they call it lichen planus, that's another topic. Now, let me see what else we have here. Okay, so again, it comes endocrine, nutritional, metabolic diseases. It comes under this category. Traumatic lesion comes under this category. In other words, you will see inflammation, but because of trauma. Trauma from what? From habit. In other words, somebody used their finger on the gum, then it causes lesion, that's traumatic lesion, and finally you will see recession or traumatic lesion because of what? Toothbrushing, traumatic toothbrushing. Then when you cause trauma, it caused the tissue react, and you will see sign of inflammation and then recession and you name it. It is not because of plaque-induced, it's because of traumatic lesion, which is non-plaque-induced gingival disease. So remember, these are under the category of non-plaque-induced gingival disease. Now, gingival pigmentation is the last category which they put it. Now, chemical insult also cause, in other words, when in dentistry they do etching, or in some patients when they use chlorhexidine or aspirin, they put aspirin on the gum to alleviate the pain, it causes gingivitis, which is non-plaque induced gingivitis. It causes inflammation. Then these things can cause, in other words, these chemical agent in a patient can cause what? Can cause non-plaque induced gingival disease, which is dentifrice detergent, paraformaldehyde, calcium hydroxide, paraformaldehyde. Where did they use? They use in endodontic treatment. And now are they using nowadays? In the past they use paraformaldehyde. And in some patients there is a reaction toward that. Now, then cocaine also can cause chemical, in other words, can cause gingivitis. So if you see a patient which, from plaque point of view is good, that is cocaine user, you should be suspicious of this problem. So in other words, you need to advise, stop that or whatever. So remember, these are important. As a hygienist, you need to be aware of that. Now, when you see when you see aspirin burn, also make sure that the patient doesn't use aspirin on the tissue. Just eat it, not put on the tissue. So, now, Next one, let me see if it goes back. Four. Okay, neoplasm. Now, am I going backward or forward? Let me see. Okay, neoplasm, we talked about pre-malignant and malignant. Now, in pre-malignant, these two conditions, and in traumatic lesion is the next one, which I talked about that. And in malignant, you will see those situations. In other words, leukemic. Now, does all leukemic patient will have gingival inflammation or not? Or some of them will have, some will not. So in other words, you can't say that each leukemic patient should have non-plaque gingival disease. And in the book, it is not written that each patient should have it. Now, did they put that, in order to rule that, they need to have a study to see every leukemic patient at a time, to see if they see gingival disease or not. Now, how can they say that this gingival disease is because of pre-existing gingivitis, then the patient got leukemia, or it's because of leukemia? Unless somebody has the record of the patient, which has no gingivitis, and then leukemia developed, and then they can see gingival inflammation. Then you can say that this patient is because of leukemia, you see this situation. Otherwise, it can be a modifying factor aggravating the previous condition. Now, do you get the point? If you don't get the point, you should be thankful that you don't have the pointer, because otherwise you need to press it until it works. Okay? So this is about traumatic vision. Yeah, I mean, sometimes it is better to divert from one situation in order to understand that situation. Okay? So in other words, don't hesitate. Whenever you don't understand something, go back to something else. And then you understand that thing which you didn't know before, and then you come back. So then, and you will enjoy that. At least I enjoy that. Okay. Or I will go into another thing, and then I will come back. Then everything will be easy. Okay? So traumatic lesion, I talked about traumatic lesion. Now next thing, again my exercise start. Exercise. I think I should use both hands so that this hand also gets exercise. So we talked about that. Neoplasm, pyogenic granuloma. You see pyogenic granuloma. Now where do you see pyogenic granuloma? In which cases? In which cases? In pregnancy. In pregnant patients, you might see pyogenic granuloma. In other words, you see something like that. Now, yes? I'm going backward? Okay. Oh, you want me to go backward?
Go forward.
Go forward, okay. So let me see. Again, okay, so I'm going forward. Is this forward or backward? Forward. Backward? Okay, so we go forward. Forward, you see, it doesn't go forward. It doesn't.
I think you have to aim at the computer.
Okay. Okay, so let me see. At the computer. She's right over here. Okay. Thank you. Thank you for that. Anyway, I'm doing my exercise anyhow. Okay. So up to here, do you have any question?
I think we can go forward with this.
With this? Okay, so let's go with this. Okay, so going forward. Thermal insert. It is good to have somebody from IT. Okay. Of the class, yeah. Idea of the class. Excellent. Okay. So, Bernal mucosa. When do you see Bernal mucosa? When you use hot pizza, yeah? Then you get that. Yes.
I have a question.
Go ahead.
On your study guide, it's
Oh.
just for the gingiva and gingival diseases, right?
Yes, yes.
Not perio, anything perio.
This chapter is about gingiva and gingival disease.
But the study guide is also only on gingiva and gingiva disease, so I just wanted to see.
Okay, this study guide which write you how is about these two chapters.
Okay, okay.
That's it. Okay? It's not about the rest which I will have it or you will have it later on.
Okay.
Okay? Now any other question? No question. So that is Bernal mucosa. Is non-plaque induced what? Gingivitis. Now, pigmentation. Pigmentation, why they put it under non-plaque induced gingival disease? Is pigmentation, for example, melanoprechia, smokers' melanosis. They put it under what? Non-plaque induced. So that's classification. So you need to know that. They put it under this category. So when we ask about gingival pigmentation, you remember non-plaque induced gingival condition. It is not disease. That's why they put condition. Gingival disease and condition. And you will see again and again. Condition, that's because of that. Now, drug-induced pigmentation, on these drugs, you can see pigmentation on the gingiva. Anti-malarial and then minocycline drug. And then the last thing is amalgam tattoo, which you do, the dentist do free of charge. Okay? So, that's the free of charge tattoo. In other words, if I ask you which one of these tattoos are free of charge, is what? Actually, it is charged, but not for the tattoo. For the tooth, which they charge for the tooth, but not for the gingiva. So gingiva get it as a complimentary, as a complimentary. So that's about this one, and this is the end of the subject. Now, if you want me to go back, I will go back. If you have question, go for question. If you have answer, let us know or let me know. Okay. So yeah, and anyhow, right now, any question? If you don't have question, so remember, in the gingival condition, disease and condition, we do have healthy gingiva. We do have healthy gingiva and reduced periodontium. In disease, we do have what? Plaque-induced gingival disease, and then it is biofilm plaque. Biofilm plaque-induced gingival disease, non-biofilm plaque gingival disease and condition. Now, condition, which one was condition? For example, when we talk about pigmentation, you wonder why they put it there. Why they put there? Because finally they decide they need to mention about, for example, gingival tattoo. Where they can put it? They put it under gingival disease and condition, and then the problem solves. So that's the basic thing. And then you remember that there is some factors which modify gingival disease. Those factors, you need to know that. Now, I'm not asking you to memorize that, but when you get to those factors, you need to remember, this is a factor for this category. Gingival disease, plaque-induced, biofilm plaque-induced gingival disease, or non-biofilm plaque-induced gingival disease. Modify the condition. Now, modify the condition, how it modified? It caused more, in other words, it pronounced the situation. It makes the situation worse. Example is what? Malnutrition, vitamin C deficiency. If the patient has gingivitis, it will get worse. If the patient has no gingivitis, it might get non-plaque induced, because it comes under non-plaque induced gingival disease and condition. Okay? So the whole chapter is about that. And you know that gingivitis is prevalent in each category, in each group, regardless of age. You will see in very small kids up to, old person. Now, you know that, control of gingivitis, which is done by you guys. By what? By motivating the patient, first of all, to make a good plaque control, if it is plaque induced. If it is not non-plaque induced, you need to detect, okay, because you do have questionnaire. From questionnaire, you determine that this patient has malnutrition. Therefore, you need the patient, in other words, you have a very good role to prevent further loss of tissue which goes to periodontitis by doing good debridement and also motivating the patient to do plaques control every day. You can prevent. So this is very important. Okay? So in other words, this chapter is very important so that you realize, first of all, these are the situation. Don't think that everything is because of plaque. It can be some systemic factor or immune system or whatever. You know that you need to get a good history from the patient, and to get a good history from the patient should rely on you. You should show that you are a reliable person, which each one of you are, but the patient should know. And the patient, how do we know? When they see that you care for them, then they know, then they believe you, and then we will have a better society. Now, I think my time is up. So next week it will be midterm exam. Make sure that you check the book, check each page, first paragraph or first line to see what is about, and then you will get some, or each paragraph, just the first line to see what is about, and then make sure that you see all pictures and actually read the picture so that you get the whole material. Then you will have no problem in your exam and later on. So any question?
So next Monday is our midterm?
Yeah, next Monday is midterm exam.
And we're going to have a proctor?
Yes.
And then we leave after? Or we have?
No. After that we do our class. I'm going on periodontitis.
So we are moving
So
on to
next
that.
stage from this, yeah. Yes.
How many questions on this?
Say that again.
How many questions?
How many questions? Exactly 40 questions. And you have 45 minutes. So you do have 5 more minutes for...
There's no true false. They're all multiple
yeah,
choice.
all multiple choice. So you should know your material, then it is very easy. So if you don't know your material, then you will get into bumper and bumper. So, yeah.
Are the questions like the ones that we've been taking?
Exactly. I'm trying to give you a quiz. Because of that, you should have no problem with the question. Yes.
Did you mention earlier that the questions in in the book, in the back of the chapters, there are some that you would use in a test. Did you say that?
Okay, no, the question, no, I, up to now, I use the book. I mean the material.
From gingivitis?
From gingivitis, from every chapter. I use the whole chapter. I didn't use the question from the book. I didn't use it.
Can you repeat that? I don't know.
Okay, so the question which you will see is from chapter, each chapter.
Okay.
Okay?
But you don't use the actual book questions that are on the back?
No, I didn't do it, no.
Oh,
No.
They're a little altered. They're altered.
okay. Okay.
No, the actual question which is on the back, no. I didn't check that. I went to the chapter and I got the question. Okay? So good luck for every one of you. If you have any question, I will be more than happy to answer. You can check me on 4th floor or in Clinic 4 or in the street or in the car.
I would say if you studied your PowerPoints, a lot of the material is on your PowerPoints.
Yeah, listen to her
And-
because
and-
she knows better.
And he did do study guide for you. But I would study the PowerPoints. I saw the majority of the questions came from your PowerPoint material.
But you did also see questions that weren't on the PowerPoints at all and just in the book.
Did you check that? I didn't
That
check.
I wouldn't say. Cause yeah. How many did you actually look at the
No, I
material
didn't.
online and take any of the questions from the?
No.
No. Okay. So I would study your PowerPoint.
No, I got from the book, so I don't know. It might be all in PowerPoint. It might not be because I didn't check PowerPoint at that time.
Did you get any of the questions from material in the book though? Correct.
All from the book.
All from the book.
We're kind of confused. I'm not confused. It's just that, you're saying the PowerPoint and the book, there's like 600 slides of PowerPoints, and then you have to read so much from the book. It's like, we don't have that time.
We need to focus
So
on one
we want to
thing.
focus
I
on
tell you what, I use the book. Now, she saw my question, so she know better that it is from the PowerPoint or not. I use the book to get those questions.
He uses the book to create your PowerPoints.
Yeah.
So that's why I'm saying kind of focus on your PowerPoints. And I know that a lot of the material that are on your PowerPoints are directly from the book.
Yeah.
So they're kind of like hand in hand. It's just I know you're trying to get the gist of the exam. Unfortunately, I don't. You know that, Kimba?
Because, even if it was, sorry to cut you off, but even if it was, you just said just the PowerPoints, there's like 600 slides. Or more maybe, and.
Or more.
We can't look at the week and look at 600 slides.
I understand. That's why I told him not to. What he was doing primarily when he was first started lecturing, like the first lecture, then the second lecture, he did a lot of review. I told him stop doing the review because that makes the PowerPoints larger. So I told him to stop reviewing too much when he doing the new lectures. So I think from lecturing now on, there's not going to be review sessions in your PowerPoints. So it'll just be new material. So I don't know if that helps you much, but he did do study guides for you as well too, if you want to check the study guides.
Are those ones the modules?
Yes, yes.
So study guides is just a smaller part of that. So.
Good luck, guys. I mean,
Yeah.
good luck.
Okay.
Thank you.
Okay. Thank you. Good morning.